persons and as persons who are working in this field that child abuse is a very big issue in Jamaica. It's we all have a concentrated effort wanting to protect our children, our most vulnerable, but there's so many ways in which they're being abused and exploited, and that doesn't look one way. And one of the things that we are trying to do with this series is sort of delve into what the statistics are saying and how we can use information and data to drive meaningful change. At JN, and I think largely because we are a youth organization and we want our stakeholders to take us seriously as young people, we do rely a lot on data to inform our work, to ensure that we are coming from an informed place in terms of how the issues that we're advocating for are in fact impacting children and young people. And so we always love to see when time and energy is put into research around the issues that are affecting people, especially when it's very timely. We hate it when it's a case where we are relying on data from 10 years ago. And so we love it when organizations are focusing on ensuring that we have real-time updates on how things are affecting persons. And so that's what this series is all about. We want to focus on today, health, but in our other sessions, we are also going to look at child protection and we're going to look at education. And we're bringing together stakeholders who will be able to share on what research is happening in their areas, what they're seeing, what is the latest, and then also to just have open discussions about how we can use the research that we're seeing to develop meaningful programs and policy. And so that's really what it is about. We rely on it a lot. We see it in the work that we've been doing around HIV. The last 3 years, youth have been the highest rates of new infection. And so we take that information and we see how can we engage young people to ensure that they are protecting themselves. What are the gaps in why, the rates are so high, and how can we bridge that gap? We do it with our nutrition work. A lot of the research that we have around there that are telling us about the early stages of non-communicable diseases that are manifesting in young people reinforces the need for the school nutrition policy, now finalized, by the way, and why it is that we are supporting these calls that are happening for the finalization and implementation of the policy and for the betterment of ensuring that our children are protected. So child abuse doesn't look one way, exploitation doesn't look one way, but we all are trying to do our part. And so even today, we have 3 excellent stakeholders who are experts in their fields who are going to share with us about some of the health-related data that we want to be very mindful of. And then they also join us for a panel around some strategies that we can look forward to working together towards. So thank you so much for coming. I hope that you are able to stay on if it's raining where you are, that your Wi-Fi doesn't cut. And we welcome your active participation. Please type your questions in the chat. And when we get to the Q&A part, be very open with sharing and those sort of things. So I do turn over back to Deshaun.
All right, thank you, Shanique. That was quite well said. I love how you really, nailed it with the idea of data to action. I think, especially now, we're constantly surrounded by data, whether it's national surveys, global studies, and a lot of information coming at us at a very fast pace. But the real power lies not in the information itself and the collection of the information, but what we do with the information, whether we're using this data, the studies, the evidence to, drive our advocacy, to call for policy, to inform policy development, to stir stakeholder and public engagement, and how to hone or to develop or strategies and responses and how we intervene with the issues that affect our country, that affect our youth, and the issues that we're so very passionate about. And so I just want to preface as well by saying that this session will be recorded. I'm sure you'd have seen the notification, but going ahead. Also, if you have any questions or queries, you can just throw them in the chat. I'll be monitoring throughout the discussion. But just to get your word out there, you can just type it to me. And so to begin, or to dive in this afternoon, we have our first presenter, Miss Novia Condell, who is a health specialist at the UNICEF Jamaica. And so Nova will present findings firstly from the multiple indicator cluster surveys, which is just a globally standardized tool developed by UNICEF to track key indicators on child health, education, protection, and other factors. She will specifically focus on the impact of violence on adolescent health, drawing from the 2023 Jamaica Violence Against Children and Youth Survey, the VAX. Just want you guys to get familiarized with these the shortenings for these words. So the mix, the VAX they'll be used a lot during the session and the presentation in general. She'll also be discussing data which shows some really alarming statistics, some sobering statistics. And these are information and survey and results that we can't afford to ignore. So without any further ado, I want to welcome Novia Kandel and I want you to ask you to help me welcome her as well.
Thank you so much, Dashawn. It is really a pleasure to be here, and I have a slightly longish presentation, so I want to go right into it. Will you be sharing from your side? Or should I share?
You can give us a second, please.
Sure.
Would it be possible for you to begin while we get the slides up?
Sure, no problem. So as Dashawn said, I'm about to go through some survey findings from the Jamaica Violence Against Children and Youth Survey. Survey was conducted in 2023 and shared nationally last year. It's still fairly fresh information. And it sets us up to look at violence and the impact on adolescents and young people in Jamaica, children, adolescents, and in terms of their health. So I'm just gonna go ahead and start while you're pulling it up, Dashawn, because I know we have other folks who will speak. So just to talk a little bit about the objectives of the study. It was mostly to estimate the prevalence of physical, emotional, and sexual violence among Jamaican young people. And the age group that was surveyed was 13 to 24 years. Look at or to estimate the association between violence and HIV risk factors, to identify risk and protective factors for violence, the health and social consequences associated with violence, and hopefully some areas for further research, as well as to assess knowledge and utilization of services for children who have experienced violence. A quick word on the methodology. It was a national household survey. It is a nationally representative survey. So these findings are really important for how we program for young people in Jamaica. It was a split sample. So we did a sample of girls and then a separate sample of boys. So it's very clearly delineated in terms of those differences between males and females. Extensive training, the protocols, in the protocols and use, how we apply the interview methodologies, and importantly, I won't go through all of these, but importantly, for the more sensitive questions, people could self-report. They were able to listen to the question and pick an answer. They didn't have to self-report to an interviewer, which we thought would get us a little bit more of what's real, when I don't have to deal with whether I've been through something that I consider shameful or I consider that I find it very difficult to talk about. I didn't have to say it to the interviewer. I could just have my own time, listen to the question and answer on a device. So that was a very important element of the study. Very quickly, 757 females and 755 males were a part of the study. And as I said, the age group was 13 to 24 years old. I can share if we're having a problem, Dashad, should I? Because I'm about to get into the findings.
I think we're currently
Almost.
working on it, but if you can share in the meantime, you can go ahead.
Oh, okay. All right. Let me know if you can see it.
We can see it. Thank you.
Excellent. Okay. All right, great. So and we can skip a few slides. Oh, just wanted to say it was a partnership led by the PIOJ, Jamaica's PIOJ, along with UNICEF, CDC, Statin, UE, and a couple of other partners. Very collaborative effort. And we get into some of what we were able to glean. So what we found is those who were aged between 13 and 17, just some of the characteristics of the group, the age group among children and youth. More than 9 in 10 attended or completed secondary schools. About 1 in 4 girls and boys experienced food insecurity. More than 1 in 10 females and 1 in 5 males worked for money or other payment in the past year, have been employed in some way. More than 1 in 10 females, which is 15%, and 31% of males reported that they had ever had sex. And more than 1 in 10 females and males had lost one or both parents in childhood. With the 18 to 24 age group, some of the background characteristics, 1 in 2 females, or 52%, 70% of the females and 70% of the males had completed or were attending secondary school. 1 in 4 females, around 24-25%, both males and females had experienced food insecurity. 2 out of 3 females and males had worked for money or payment in the past 12 months. 72% of the girls and 73% of the males ever had sex. More females than males were ever married or cohabited in that age group. And so can we mute the mics? More than around 10% of both had lost one or both parents in childhood before age 18. So what do we know coming out of this study? And it really is cementing some of what we have known as well before, that violence against children is quite a common phenomenon in Jamaica. More than 3 in 4 females and males in the age group had experienced physical, sexual, or emotional violence. That's nearly 80% had experienced some kind of violence in their lifetimes. More than half of the females and males had experienced, in the 18 to 24 group, had experienced physical, sexual, or emotional violence in childhood. All types of violence against children and youth are common with some sex differences. Now, if you look across the board at any type of violence, it's pretty much even. It's nearly 80% of young people, 13 to 24, who had experienced any type of violence in their lives. Physical violence, we see that there was 61% of males compared to 53% of boys. Sexual violence, 36% of girls and 23% of boys. And emotional violence, girls tended to experience that more at 61% compared to 52%. More than half of the children and youth who experienced physical violence had experienced that first incident in the 12 to 17 age group, right? So both girls and boys, it's a very much across the board in that regard. But we also can look at the fact that around 28% of girls 6 to 11 and 31% of boys age 6 to 11 were experiencing physical violence. Sexual violence is common in childhood, and girls are much more vulnerable based on the reporting. 1 in 4 girls had experienced sexual violence in childhood, and 1 in 10 males. Significantly more females than males had a lifetime of sexual violence. 36% of girls compared to 23% of boys had experienced any type of sexual violence. When it came to unwanted sexual touching, girls again experienced that more than boys. Unwanted attempted sex, 20% of girls, 12% boys. Pressured or coerced sex, 8% compared to 3% of boys, and physically forced sex or rape. Well, so much of this is what we will call that rape. 14% female versus 11% male. Many victims experience sexual violence, first experience sexual violence at age 13 or younger, and we saw that in an earlier slide. So it begins quite early in life. Nearly 1 in 5 females had their first sexual experience being physically forced or pressured, nearly 20%, 1 in 5, as compared to 3% of males. And of course, what we know from previous surveys years ago rings true still. The most common perpetrator is somebody known to the victim, usually a friend or neighbor, and that is true among males and females. And interestingly, 27% of females said their current or former intimate partner was the perpetrator, and among males, nearly 50% said the current or former intimate partner was the perpetrator. Children and youth are exposed to severe forms of community violence, so it's not just at home. It is also around us, as we know well. 34% of females and 42% of males between 13 and 24 saw someone stabbed with a knife or sharp weapon or shot with a gun outside of the home. 32% of females, 30% of males know somebody who was murdered. So that also we cannot discount the emotional toll of community violence on our young people. Children and youth who experience sexual violence are not getting the support and services that they need. What they have told us through this survey is 53% of the girls said they told somebody, compared to 35% of the males. Among the females, 40% knew of a place to seek help, while only 31% of the males did. 10% sought services, and 7% received services, while among the males, 10% sought services, 8% received services. So this is a lot for us to think about, those of us who are in the service delivery sector. How is it that we're making sure that people know where to go? How is it the services are rendered and delivered to the satisfaction of the person who is seeking it? Where do children and youth go for services? Among the females, the highest report was to police or other security personnel at 63%. And around that 60-something, low 60s% there, you have social workers, guidance counselors, critical personnel at the school. If you will recall, during COVID, we actually saw a dip in reporting, and it is being put forward that it was because schools were closed and young people didn't feel like they had a space to report. CPFSA, OCA, among the males, 99% who did go for services said it was a healthcare worker that they spoke to, that they went to get services, and 54% to the security personnel. So some of the associated negative consequences and risk factors that came out of the survey: females who experience lifetime sexual, physical, or emotional violence were significantly more likely to have mental distress in the last month, were significantly more likely to have thought of suicide, and were significantly more likely to intentionally harm themselves. Females who experience a lifetime of sexual violence were significantly more likely to binge drink and to also ever have had symptoms or diagnosis of STIs. Females who reported a lifetime of emotional violence were significantly more likely to we already said that. There's a repetition right there. Among the males, males who experienced a lifetime of sexual violence were significantly more likely to have smoked cigarettes or marijuana in the last month. They were significantly likely to have, those who experience a lifetime of physical or emotional violence were significantly more likely to have mental distress in the last 30 days. And those who had experienced a lifetime of emotional violence were significantly more likely to ever have had symptoms or diagnosis of STI or smoked ganja in the last 30 days. When it comes to sexual risk-taking behaviors, among those who had a lifetime of experience of violence, early sexual debut was a feature among 11% of girls and 37% of the boys. 11% of the young women in the survey or the girls in the survey reported that they became pregnant before age 18, and that question was asked, of course, among the older age group. Binge drinking in the past 30 days among the 18 to 24s, 12% of females and 21% of males. When it comes to other sexual risk-taking behaviors such as transactional sex, 10% of girls reported in the 19 to 24 age group reported that they had received goods, money, or services in exchange for sex. Meanwhile, 17% of males had provided goods, money, or services in exchange for sex. 27% of females reported they had 2 or more sex partners in the past 12 months, compared to 63% of males. And infrequent condom use was fairly common, 47% of females reporting that, and 58% of males. And thank you very much for your attention. Back over to Dashawn, am I handing back to you?
Yes, thank you so much, Novia. Great presentation indeed. Before I say what I was about to, I'm seeing a comment from Sharika Mills in the comment section. She's asking, when you say a lifetime of, what does that mean? And how long or how often would a person have to experience violence before they can be considered to have experienced a lifetime of violence?
Okay, so it has it ever happened in your life? So those persons who had experienced it in their lifetime exhibited certain behaviors and certain risk factors. So it's not necessarily the frequency, but it's more about having experienced it within your lifetime, whether sexual, physical, or emotional violence.
All right, thank you. And I hope that answered your question, Sharika. If anybody else has any other questions, you could either post them in the chat now or you could wait until the panel discussion section. But in the meantime, I'd just like to thank you for your presentation, truly insightful. And I also liked how it somewhat aligned with the overall theme for Child Month, which calls us to act now and, stand against violence, being perpetrated against children and child exploitation, and how the statistics kind of paint this image of the state of child violence in Jamaica and the need for urgency in our action to mitigate such violence being perpetrated against our children. And I also like how you discuss, the linkage between early childhood experiences and how that affects predisposition within these individuals, leading to lifelhood or lifelong mental health issues, how it affects their ability to interact with others in the future, form healthy relationships. I feel like that really stuck out. So once again, thank you for your presentation, Novia. And we're going to go straight ahead into our second presentation. Our presenter is Patrick Lilo, or Mr. Patrick Lilo, who is the advocacy manager of the Jamaica AIDS Support for Life, that's JASL. And he's also a long-standing advocate for vulnerable and marginalized populations. Now, Patrick brings with him over 15 years exactly of experience in sexual reproductive health rights, legislative advocacy, youth protection, you name it, he brings it all. And today he will talk us or walk with us through the realities of adolescent sexual and reproductive health in Jamaica. He'll be looking at access to services, the gaps in comprehensive sexuality education, and how sociocultural norms, legal barriers, all of that affects youth. And his insights will, of course, help us to understand how to better respond to adolescents' needs, particularly in the context where risk and vulnerability, are high. And so please help me to welcome Mr. Patrick Lilo. Over to you.
Thank you very much, Mr. Chair. Am I being heard clearly?
Yes, we can hear you loud and clear.
All right. Thank you for having me. Let me just start by saying here at Jamaica AIDS Support for Life, outside of our programs for orphans and vulnerable children, we don't really work with children for treatment of HIV and other STIs, but we do provide services for adolescents and youth. And so the data I will give you around prevalence and persons in care comes directly from the Ministry of Health. But as it relates to HIV education, addressing stigma and discrimination, and legislative advocacy for, we do that for everybody. So just to start, let me say generally the general data shows that currently, as the data stands, there's an estimated 29,000 persons living in Jamaica with HIV. That's a 1.6% prevalence rate. And the data shows that 16% of this estimated amount are still unaware of their HIV status. Now, when we look at this number, we're talking about, when we look at the adolescent age 10 to 19, there's approximately 1,500 cases, 800 plus being boys and almost 700 being girls. The mode of transmission for children who end up being HIV positive is generally vertical transmission, that is transmission from the mother to the child. There is sexual transmission where we look at children who has early sexual initiation, starting sex early. And there's also the issue of sexual abuse, which is a critical area where we need to improve not just our advocacy, but our policy and legislative framework. Now, the reality is in 2024, May to be exact, I think it was May 7th, Jamaica received certification from the World Health Organization that it has successfully eliminated vertical transmission of HIV, that is mother to child. That's in 2024. So, and maybe we can talk about this later, but I wanted to start thinking if we have children living with HIV who are not, and it wasn't transmitted from the mother to the child, where did they get HIV from? So outside of early sexual initiation among kids and young people, then the issue of sexual abuse of our children comes to the forefront when we look at the data. Because if we have been successful in eliminating mother-to-child transmission, then it begs the question, where do our children and young people get HIV from? The latest EPI-data shows that the 15 to 24 age group accounts for the highest number of new infections of HIV. That is 15 to 24. So we are basically talking about a great number of our adolescents, and we are talking about people who are still minors, just becoming an adult, or basically just about getting out of university, entering into the working world. This is where we are seeing the highest number of new infections. And that is something for us to consider. Now we have approximately 500 children in the 0 to 14 age group. I said 1,500 earlier, that's 10 to 19. But if we should separate the numbers to look at who we'd consider minors, between 0 and 14, we'd have approximately about 500. One of the greatest challenges that we continue to have is the issue of knowledge and attitudes towards HIV and towards the information broadly about sexual and reproductive health. The latest KPB survey found that there has been a decrease in knowledge, where as high as 33% of those surveyed young people did not identify with consistent condom use or other methods of protecting themselves from STIs and pregnancy and all those things that comes with having sex. So the survey shows that knowledge based on the last survey has not improved, but has gotten worse. That is something for us to think about, because then it begs the question, why has knowledge increased? Have we ceased doing public education? Are our children and young people not getting enough information? And then this will bring me over to the health and family life education, the HFLE curriculum, which is one that we have done. The Ministry of Education, to be specific, has done a lot of work around improving the curriculum. As an organization, as JASL and some other civil society partners, I know we participated in the review and improvement of this curriculum. So we now have a fairly good curriculum that is being implemented in most schools. It is, for the most part, very consistent between grades 7 to 9, not so consistent between 10 and 11. We have a cadre of dedicated HFLE teachers who have been trained in the delivery of the curriculum. But where the gaps remain is that it remains an area that is not consistently delivered. So, HFLE is the stepchild in school. You are not examined on it. There's no exam to pass. There's no test to be done around health and family life education. So if we have any sort of disruption in the schools, any challenges, if we lost the maths teacher and it took us 2 months to replace the maths teacher, then the easiest spot to push aside in order to catch up with the math sessions would be the HFLEs. So there's not that consistency in the delivery of the curriculum. So although there's a good curriculum, there's no consistency in the delivery of it. And there is still that attitude of a lot of adults, parents in particular, and the general public. There is the influence of the church on the school, that we shouldn't be having these conversations with our children in school. Yet there is no shortage of incidents of children having sex in schools, our children engaging in different sexual activities in school. Yet we still have drawback from parents, from the church, and even from some of our policymakers to say that we should be having the conversation around sex with school. No matter how we put forward having the age-appropriate conversation, and I'm minded to think carefully when we talk about age-appropriate conversation, because even what the general public would define as age-appropriate for our children, when we see some of the conversations that they are engaging in at 12, 13, 14, 15, and that they are engaging in sexual activity, then we wonder why there is this opposition to the conversation being had. But that is something that we think there's a strong correlation between the fact that sexuality education, comprehensive sexuality education in our schools is absent. And then we ask the question, why don't our children have the correct information? And this leads to the reality is we want to say, don't have sex. It's not something that you should do until you're an adult. And we can say that all we want, but we know what the realities are on the ground. And I think people misunderstand providing our young people with the correct information and commodities to be able to protect themselves. That is often construed as giving them the go-ahead to engage in sexual activity. So we get a lot of opposition and pushback. You go into schools to do a general presentation around HIV, STI prevention, and before we enter the classroom, you get a long list as to what you cannot talk about. And I can share an example. We go to school to make a presentation and they say, don't talk about oral sex, don't talk about condoms. And they gave a long list. And then we ask ourselves, what is the purpose of the presentation? But we do a sanitized version of the presentation. And then when we say any questions, then all the things that we are told not to talk about come up in questions from the children. So, many times when we get in these positions and we are told not to talk about it, we don't worry too much about it because we can guarantee that before the discussion is finished, we'll get a question about oral sex from a kid, we'll get a question about condom use or contraceptives from a child. So all those things that we are told not to talk about. So this is something that our advocacy need to be strengthened around in terms of comprehensive sexuality education, better delivery of the HFD curriculum, and a mechanism to make it more, make it an important part of the curriculum. I think it's not seen as an important part of the curriculum, and as such, it is easily brushed aside if time is needed to catch up on any other subject matter than the HFLE suffers. There needs to be more training of the teachers that are tasked with delivering the curriculum again, because we find that on one hand, we have a good curriculum with the correct information that can help our young people to protect themselves, but then we have a teacher who is uncomfortable with the information in the curriculum, who is uncomfortable with delivering that information. So you find that the information is there, the HFLE session may be held, but that information is not delivered. The curriculum also has to be reviewed on a more regular basis. We generally find that the representatives of the church are at the table and are an integral part of this discussion. And there is always this issue of morality that is taking the forefront, and such acts are not moral, and our children should not be doing this. And as such, a lot of things that should be in the curriculum gets left out. I think we have to do a more consistent, more regular, maybe no more than 5 years. I would say 3, but considering how long it takes us to review anything policy or legislative in this country, if we get it every 5 years, that's something that we could settle for. But definitely, we have to have the curriculum constantly reviewed, and we have to do more work around getting comprehensive sexuality education in the school. The KAP survey also showed that stigma and discrimination remains one of the barriers, with many individuals not accepting HIV positive individuals. So we find that a lot of our young people who are infected with HIV do not readily talk about it. Some of them are not in care as they should be because of fear of stigma and discrimination when they come to access services, sexual and reproductive health services in general. And I want us to get that this is not just about HIV, but sexual and reproductive health services in general are not as accessible for our young people. Or government will say, yeah, the facilities are there and the services are there, but a lot of the restrictions, a lot of the judgment that they face when they come into these facilities make them not want to come forward. They don't feel comfortable talking to the people who are in these facilities, the people who are sometimes very judgmental towards them, the people who sometimes spend this medical consultation ends up being a reprimand for how could you at 16, 17, 18 being showing up in here with an STI? Why are you having sex? As opposed to the conversation being around treating the health issue that the adolescent appear with and providing the information and commodities for them to protect themselves and to avoid a reoccurrence of this. It end up being a judgment session, and we find that a lot of young people present with STIs and they either stay with it or try to find some other way of dealing with it, which most times is unsafe and only harms them more. So one of the things that we do is to ensure that there's a gap in the law that we currently allows once the child has attained the age of 16. Such persons can come in for an HIV test, for example, for STI screening, and can consent to certain medical procedures as it is said in the law. But there is still some ambiguity where, depending on where this child shows up with an STI, they may be turned back to go and get their parents, and we know how that will end up. That child that is presenting with an STI, many times the parents doesn't even know that this child is sexually active. To send that child back to get the parent to come forward for the treatment, most times they remain with STIs untreated. And if we are looking like STIs like syphilis, for example, where the symptoms will go away and it can be dormant for a while and it can appear as if, oh, whatever I had, I don't have it anymore. You may find that they leave with these STIs, the symptoms go away, they think that they are okay, and the reality is they are not. So sexual and reproductive health of our young people, the data is showing that sexual initiation is happening earlier. New infections is increasing among the 15 to 24 age group, and the knowledge of how to protect themselves and how to prevent STIs and all that comes with sexual intercourse has decreased. So how are we going to fix this? There's a lot of approaches. I spoke about comprehensive sexuality education, improvement of the health HFLE curriculum and delivery, but there's also significant policy and legislative gaps that if those are not fixed, the whole issue around the HFLE curriculum, the whole issue around addressing stigma and discrimination, the whole issue around comprehensive sexuality education, and even the issue of dealing with those who are tasked with providing the health care services, this SRH services, to our young people. One of the things is if they go into these facilities and when these bad experiences are reported, the accountability mechanisms are not strong enough. And most young people, they don't even bother because, yes, I'm going to say that this happened to me and nothing is going to come out of it. So also the strengthening of the accountability systems in these institutions that are tasked with providing SRH services to our children and young people. If the accountability systems are not stepped up, then we are not going to be able to achieve what we want. And more importantly, as we celebrate Child Month, I think within the sexual and reproductive health framework, we have to remind our people, we have to remind our providers, we have to remind our parents that children have rights too. And sexual and reproductive health and rights is one of those rights that they have. And that must not be forgotten in our everyday interaction with them, and more importantly, in the delivery of sexual and reproductive health services. Thank you. That's it for now. Thank you.
All right, thank you, Patrick. That was also a well done presentation. I especially love that we can see some interconnectedness between both presentations thus far. The themes of knowledge gaps and the inadequacies of the health services, specifically sexual and reproductive health services, and that being a barrier to children or individuals seeking aid. You can see that come out in both presentations. With Novia, she would have discussed the lack of knowledge about the existence of services, health services. But in Patrick's presentation, you could have seen how knowledge played out in the inefficiencies of the current HFLE programs within schools, how we need to bolster those programs and ensure that they're actually ingrained and robust. And also the provision of comprehensive sexuality education. That's something that we advocate for here at JAN. The importance of providing age-appropriate, comprehensive, and meaningful education, and just understanding that the provision of knowledge in and of itself is not an affront on morality, and this idea of silence and shielding children from information that they need is not the solution. And so we always say that knowledge is power. And so the earlier and the better that we get this information out to the children, the more they're able to shield themselves and better protect themselves when engaging in certain activities. So thank you, Sir Patrick, for that lovely presentation. And now we're going to head straight into our third presenter, Mr. Wendell Abel. Now, Mr. Wendell Abel is a professor within the community health and psychiatry faculty at the University of West Indies, Mona, Professor Wendell Abels. He is a respected authority on mental health in Jamaica and the Caribbean at large. And today he'll be exploring mental health and healthcare access trends amongst adolescents. His presentation will look at, how stress, trauma, systematic gaps in mental health services, how all of these are affecting young people, especially looking against the backdrop of COVID-19, economic hardship and increasing violence within Jamaica. His presentation will help us confront the silent crisis of adolescent health, mental health rather, in Jamaica. So please help me welcome Professor Abel to our session. Thank you.
Good afternoon, everyone. Well,
Good afternoon.
This afternoon, I'm going to be addressing specifically the topic of childhood trauma. And when we talk about trauma, we're talking about any experience that is potentially life threatening, distressing to children. And in the context of my presentation, children, I'm looking at children under the age of 18. Now, why is this important? That is childhood trauma. And childhood trauma is important because it is common, and it's important to note that it's preventable. And when we talk about trauma, we're talking about um, abuse, such as physical abuse, emotional abuse, sexual abuse, physical abuse, a child who is beaten, or in many contexts, parents are going to murder you, they're murdered in the context of corporal punishment. And the reality is that for many children, what is put forward as punishment or discipline really is harsh and is abusive. It could be emotional or verbal abuse. You know, that child who grows up in the home and he or she is told that you're worthless, you're not going to come off anything, you're no good like your father, you know, common expressions. Um, or the child who experiences emotional and physical neglect because the parent is not there, parent absent, mother absent through migration, father absent, not there. And there are other forms of childhood trauma, such as problems within the home generally, such as having a experiencing the loss of a parent. Parent might have died, or parent might have migrated, or the parent is just not there. And you know, the reality is that there are far too many children who, even though their parents may be alive and present, they're shifted from one caregiver to another, sent to live with godmother or grandmother in the country, or an aunt, and they're shifted around. These experiences are traumatic for many children. Um, in the home, it could be a parent who may be living with a mental disorder, and that can impact on the child and the entire household and can be traumatic. Also, having a parent who uses alcohol or drugs, and this is often or maybe associated with violence within the home. Domestic violence, again, is another um, common um, traumatic experience that children um, go through within their home environment. Um, in recent times, when we talk about childhood trauma, we talk about adverse childhood experiences, or ACEs, ACEs, adverse childhood experiences. And the list of traumatic experiences that I've just highlighted are grouped as ACEs, adverse childhood experiences. And a lot of research has been done over the past 20 years um, on in this area. And what the research has shown us generally is that firstly, that the brain of the developing child is very vulnerable to stress and trauma and adverse experiences. And because of that, it can affect the trajectory, that life course of a child, literally from the womb to the tomb. And how does that manifest itself? You can have in young children, in infants and so on, you can have developmental delay. So that child was exposed to adverse childhood experiences and trauma, who probably was walking, may begin to slip back, or the child who was able to was potty trained or trained in terms of just managing their urine and so on, that child may actually start bedwetting, or a child who's going through a lot of traumatic experience may actually start sucking their thumb. And we refer to these as regressive behavior. And also, for some children, it may just be a delay, developmental delay in their normal development. They're not progressing as we expect them to progress. Um, Exposure to trauma and these adverse childhood experiences can also affect learning and education. And we find that children who are exposed to a lot of traumatic experiences do in fact have difficulty in terms of school and academic performance, and also progression in school. And may also exposure to traumatic experiences also affect children's behavior. And this is so because the child who is exposed to trauma on an ongoing basis, their brain is affected to the extent that they remain in a hyper alert state. They're always expecting, they're always anticipating danger. And because of that, they're easily triggered. So that child who probably may be in class and the teacher asks the child a question and the child is unable to answer the question may actually be daydreaming. And the term we use for that is that they're dissociating because of the traumatic experiences that they're having in their home or school environment or wherever. Or the child who is always involved in fight, maybe aggressive, that child may be emotionally dysregulated. And again, it's because of the trauma that they're experiencing. And so a lot of times when we see children with behavioral problems, we shouldn't ask what is wrong with that child. But what we should ask is, what on earth is happening to that child? What is happening to that child? Because a lot of times, the behavior we're seeing is as a result of trauma. Children don't easily tell us about their trauma and their traumatic experiences, but a lot of the trauma plays out in their behavior. And I'm by no means suggesting that all the behavioral problems we're seeing, all the learning problems we see in children, that these problems are due to trauma. Not at all. But a lot of children who in fact do have problems, educational problems, behavioral problems, may in fact be undergoing a lot of traumatic experiences. Now, later on in life, research has shown that trauma may lead to other behavioral problems such as self-harming behavior like cutting. In fact, in an emergency room setting, we know that vast majority of children who present to us in the emergency room because of cutting or reporting attempts of suicide or ideas about harming themselves, that it's attributable to exposure to trauma, especially over a long period of time. Children, a lot of children who use alcohol and other substances like cannabis, if you sit with them and you ask, you'll realize that they're using these substances to self-medicate themselves, to deal with their undergoing pain. And I often say that addiction begins and ends with pain. And I'll repeat, addiction begins and ends with pain. And a lot of time what we do is focus on the little boy, young child, not young child really, but say teenager using ganja or using alcohol, whatever. And we focus on the drug, which is the addiction, but we're not focusing on the underlying pain. Yes, and addiction begins and ends with pain. Um, and again, data has shown, research has shown, and I encourage us to read about the adverse childhood experiences, studies that have been done, widely discussed, widely done in the USA, and the studies indicate that exposure to these adverse childhood experiences, some of which I mentioned earlier, the abuse, the neglect, the problems within the home, they're also linked to a lot of the chronic diseases that people have, you know, diabetes, hypertension, lung disease, kidney disease. And what the data has shown is that the more of these adverse childhood experiences children are exposed to, is it increases the possibility, the risk of developing these diseases later in life. Of course, as a psychiatrist, I must also focus on lots of some of the mental disorders that are linked to childhood trauma and adverse childhood experiences. And some of these conditions, I mentioned them like suicidal behavior, but the conditions such as anxiety, depression, post-traumatic stress disorder, and so on. Now, having said all of that, the question you may ask is, you're talking about this issue generally, but how common um, a childhood is childhood trauma and the exposure to childhood trauma in Jamaica? And, you know, many studies have been done, and the data suggests that 8 out of 10 children, 8 out of 10 children, or 4 out of every 5 children you see, right, would have been exposed to at least one form of childhood trauma in Jamaica. And so there's a high level of exposure to childhood trauma. And the most common, of course, is violence, either within the home or community. Studies in Jamaica have also shown that 2 out of every 3 children would have been exposed to bullying and violence within their school environment. Bullying is very common. In fact, recently I gave a lecture, was talking to a group of young children about bullying and body shaming, you know, which is very common in Jamaica, where you tease children or even adults and based on, um, you know, some part of their body, you know, whether you're like for me as a child, they used to call me short man or big forehead or something like that. And we take it for granted, but body shaming is a form of bullying. And just talking to a group of young people, I was surprised. Almost 2/3 of them actually admitted to to bullying and body shaming in some form or the other. And we may probably take these as common issues and say, but when we talk about this a common something, but it's traumatic for children, yeah? And it can destroy their self-worth and their self-esteem, especially if these experiences are ongoing, you know? What is also interesting is that recently we did a study among university students, and 2/3 of them also reported that um, they experience physical abuse in the home environment. Yes, these are university students. But what was very interesting is the vast majority of them didn't realize, didn't see it as being abuse. And it speaks to the fact and to the extent to which we have normalized violence in our society. And so the data is suggesting, no doubt, that there's a high level of exposure to trauma in this society, whether it's physical abuse, sexual abuse, emotional abuse, neglect, um, traumatic experiences within the home environment. And there are many things in the society that make it worse, the exposure. A lot of practices, you know, I touched on it earlier, you know, like, I mean, practices within the home environment in terms of how we discipline our children in a very harsh way. Yes, and sometimes it's under the guise that um, we must not spare the rod and spoil the child. But what in many environment, in many home environment, what we refer to as discipline, is really physical abuse. It's harsh and and abusive. Um, a lot of family practices again um, contribute to traumatic experiences for children. And I touched on it earlier, the practice of, for example, shifting children from one household to another. A major issue for many children is a father who is not present. Yes, now many children have grown up in household where, and they'll tell you that for them it was very traumatic. Father was not there, or there was no emotional connection with their father or mother. And many children will tell you the only contact they have sometimes with their father is that the mother would send them to the father to beg money, or sometimes to be disciplined, and disciplined harshly. And it is clear for us, to us, that childhood trauma has become a major public health problem in this country. And it's something that we need to address and we need to tackle. And how are we going to do it? We have to do it by having this conversation, lifting the conversation and lifting the awareness in terms of trauma and how it can affect the child well into adulthood. Yes, but the data has shown us that the most protective, or the factor that can protect children most significantly, um, um, is actually having a trusting adult in their life, whether that um, adult is a parent or a extended family member or somebody in the community, that this is a great buffering effect. It buffers the children and protects them from the negative experiences and effects of trauma. And that is why, as a society, we have to place greater emphasis on parenting and ensuring that children are adequately prepared to become adults and equipped with good parenting skills, because we still have a society, live in a society where we have a lot of teach our children that we need to strengthen parenting education society a little bit more, so that parents know how to parent and parent properly. Also, just want to remind us that it takes a village to raise a child. And when we talk about the village, it's not the traditional village, it's a community. That earlier said that children need to have a trusted adult, an adult that they can trust, and that in their lives, whether within the home or the community, because an important role of the adults in the life of a child, including the parents, is to ensure that we prepare, we ensure that a child grows up in an environment where they feel safe, they're secure, and they're adequately nurtured. Children need that to grow up to be healthy individuals and to be productive individuals. And so beyond the the need to emphasize parenting education, we also need to work closely with schools and other providers to ensure that our system become what we call trauma informed. Yes, whether it's school, um, um, our child protection services, the welfare services, our healthcare services and facilities. We have to ensure that the systems and the people who work in the system recognize how common trauma is in our society, and also equally to recognize how trauma can affect our children, and to ensure that our systems do not further traumatize our children. And so my call this afternoon is a call for our society to become, for us to become more trauma aware, right? And for our services to become more trauma focused, our educational system, our school system to become more trauma focused, our healthcare system to become more trauma focused, child protection, and family services to become more trauma focused. All services that interface with children, police, all the services that we need to become more trauma aware and trauma focused, so that we do not we recognize how common trauma is, we're able to pick up the signs, and we don't re-traumatize our children. And if there's anything I want to leave with us, it's so important for us to be able to deal with trauma in this society, because if you don't heal from what hurt you, you're going to bleed on those who did not cut you, right? And so this is a call for us to begin to pay attention to childhood trauma, and for us to ensure that serve.
All right, thank you, Professor. You broke up a bit at the end, but I think we'd have heard you for the most part. Can you hear me?
Yes.
Yes. All right, lovely. All right, so we just want to thank you for that presentation, and I love your call to action. Um, what I, got from the session is about redirecting our focus, or perspective rather, not just looking at what's wrong with a child, but what has happened to the child. And your call for, services or education, health services, healthcare, all stakeholders to become more trauma focused and more trauma aware, so that we can end this cycle of the perpetuation of trauma, and so that we can realize that a lot of times when we see children within schools and within spaces, perpetuate or act in a certain way or in a certain manner, it's oftentimes due to underlying issues that they face within the home. I know you mentioned instabilities, you mentioned the loss of parents, you mentioned domestic violence, and the various adverse childhood experiences that can impact children, that can affect academic outcomes and all other aspects of their livelihoods. That's what we should focus on, instead of pinpointing or blaming the children for their actions. So I want to then turn to the comment section. I know that Kayla would have posed a question. She was asking for a bit of some statistics around childhood trauma affecting children, the percentages regarding the different ways trauma is manifested, but I know that you would have mentioned that I believe 2 out of every 3 children would have been exposed to bullying or violence. You mentioned also 2 out of every 3 university student would have experienced violence within the household, but these students aren't cognizant of the fact that this is abuse. And you also mentioned that 8 out of 10 children are exposed to at least one form of childhood trauma. I see also that Natalia would have said that these systems should be more accessible and consistent. I agree, and that children ought to check or get check on their mental health rather, as they do their physical health, in order for problems to be addressed early on. And other persons, Ravi says, reiterating how powerful these words are. And if you never heal from what hurt you, you bleed people who didn't cut you. So once again, I want to thank you for the presentation. I see that Noel has a hand, but Noel, I'm going to ask you to hold it for a second, because we're going to head straight into the panel discussion. And so you can pose it there. So once again, I want to thank all the presenters for their lovely presentations. They were quite insightful, thought-provoking, evidence-rich. And now we just want to unpack all of this data that we've been exposed to, that has been presented, all the interventions that have been mentioned, so that we can help to, discuss what it means for advocacy and policy focus on all other areas. So first, Noel, I saw that your hand is up. So I'm going to allow you to ask your question. I believe that question will be posed to Professor Abel. You can go ahead.
Yes, that's correct. Good afternoon, everyone. I hope all is well. My question is, how can we equip our young people to better deal with mental health illnesses? Because I know you mentioned about teaching like parents how to better grow their children, and you made mention of different institution of socialization such as a school. But I want to know, like, do you think young people have a role to play in this as well, and how can we equip them to better deal with mental health illnesses?
Well, we all must take responsibility for our health, including our mental health. And as we often say, there's no good health without good mental health. And um, the emphasis, in fact, is not even so much only on just health, but on well-being. And um, and how can we take responsibility for our own well-being? And it's to do the some of the basic things, you know. It's basic, but sometimes difficult, like basic self-care, making sure um, you know, a lot of young people studying under stress. Make sure you get your adequate stress from an early age to ensure that, sorry, you make sure you get adequate amount of sleep. I'm distracted where I am right now. But make sure you get adequate amount of sleep, and also to pay attention to your diet. You know, um, and in paying attention to your diet, although it's about physical health, it can also impact on your mental health. Stay away from the sins of food, you know, the S's, the sweets, the starch, and the saturated fat, you know, which are not healthy. And it's so important that young people develop these lifestyle habits early so that when they become adults like me, it's very easy to continue these habits. The earlier you start, the better. To be able to deal with your emotions. And this is a major one in our society, that we do not teach our young people to adequately deal with emotions, to be able to recognize their feelings and to be able to express their feelings. And and this is very important, you know. So for example, if somebody says something to you and you don't like it, that person who is not emotionally aware and intelligent, the way they deal with a friend maybe to use a bad word or put them down. Whereas you should be able to communicate, your emotions and to it quickly. And it's just whet your appetite, just introduce the concept of using what we call an I message, which is to say, I am disappointed because of how you spoke to me, and what I would have wanted is for you to speak to me better. It's the way we communicate emotions rather than being aggressive and being disrespectful to each other. And I want everybody listening up to us to me this evening to go and read about iMessage. Can't teach you all of that in one session, but the point I'm making is just to be able to deal with your emotions and to be able to communicate with your emotions, which is important. And of course, to be able to deal with common problems such as anxiety and those things, you know. And part of that has to do with just general self-care and taking care of exercising and dealing with learning to deal with problems on a daily basis. But those are some of the simple things that we can do as young people to just manage and maintain our well-being and our mental health.
All right, thank you, Professor. And I just want to point out something that Trevisa would have sent in the chat, just highlighting one of the support mechanisms or services that are available to young people. The U-Report platform, which is, brought to you by UNICEF Jamaica, in collaboration with the Ministry of Health and Wellness. It's a mental health chatline, so I invite you guys to check out her comment, and just use the services that we have available to your benefit. And I'm also going to invite Rosanna. Rosanna, I think we believe you have a question for Professor Abel. Okay, so I'm not hearing Rosanna. So Professor Abel, in the meantime, I'm going to ask you a question. I'm going to ask you a question. I know that you mentioned the three S's, so the sweets, the starch, and the saturated fats. And interestingly, I just want to know if there's any correlation between, food and mental well-being and the development of children, and how malnutrition can affect their mental capacity. I know advocacy is something that nutrition advocacy rather is something that Gian is really focused on or passionate about. So I'd love to see if there's any interconnection between those two areas.
All right, all right. Nutrition is very important, of course. And in fact, whereas years ago we had major concerns with poor nutrition, undernutrition, nowadays what we're having is we're having an obesity crisis, right? And it's because a lot of, especially among our young people, it's a growing problem. And again, it's because they're consuming too much sweet, too much starch, too much saturated fat with the fat, fast food and that sort of thing. And it's important, and as a result of this, our population is becoming increasingly more and more obese, and that is leading to a lot of chronic disease problems. So our young people are not being taught to eat as healthily as they should right now. And then 10, 15 years down the line, they're going to be having the diabetes and the high blood pressure and other problems and the obesity and so on. And we'll be spending a lot of money to be able to maintain their physical health. And if you're not enjoying good physical health, you're not going to enjoy good mental health. But we also do know that nutrition can, in fact, affect your mental health. You have to ensure that you eat properly, nutritious food, and in the right proportion. You're not overeating, and we're staying away from a lot of the unhealthy fast food and so on.
All right, thank you, Professor. And I'm just going to call on Novia. I'm sure you'd love to chime in on this topic, the interconnectedness between nutrition rather, and mental health. But also, is there some link between nutrition and childhood violence, the perpetration of violence in Jamaica? Just what are the linkages between those two topics?
That's a question for me or for somebody else?
Oh, for Novia or other panelists. Novia Connell. I don't know if you can hear me. Novia, are you with us?
Hi, Dasha. I'm sorry. Can you repeat the question?
So,
Before Novia
Professor,
answer, unfortunately, I'm going to have to run because I'm actually at hospital right now. So I have to run, but I hope that the panelists will be able to answer some of the questions. I'm sure they will. But thanks for this opportunity and sorry to interrupt.
All right, thank you, Professor. It was a pleasure to have you and enjoy the rest of your day. Okay, so Professor Abel was recently speaking on, or just previously speaking on, the connectedness between nutrition and mental health, or the manifestation of mental health issues within children. So I was posing to you if there's, you could speak also on, the linkages between nutrition, mental health. Are there any linkages between nutrition and the perpetuation and manifestation of violence within children? I'm sure you'd have some stats or any information about that.
Thanks. That's a great question. I don't have stats, but there is quite a bit of research emerging now about the connection between the diet and the mental health. As you know, it is the food that we eat that feeds our body, that allows different systems inside of our bodies to work well. And we're finding out that there is a very, very strong connection to what you eat and your brain's ability to function well. And because as well, young people in the teenage years, the brain is going through a tremendous amount of development and it needs to be properly fed. We need to make sure that young people understand nutrition and the impact on their brain health, because a lot of development is happening in the teenage years. The teenage brain is really a wonder to study, as the systems move to make sure that you're able to function well, and bringing in, you know, as well as the impact of hormones, all those hormonal changes on brain development. And so feeding the brain right is a critical piece. As Dr. Abel said, those S's, the sugar is a big problem for the brain. I've seen recently they're connecting over intake of sugar to things like ADHD, to anxiety, to many different issues that young people face with that impact on their mental health and their ability to function well. And it's really critical that one, young people are informed. Two, our food environments are addressed and are able to be sensitive to that time of your life, and making sure that young people have access to good and nutritious food. Also parents, to make sure as well that parents are aware of the impact of some of the impact of non-nutritious food on the child's brain development. It is absolutely critical, and the research that's coming out now is pretty staggering.
All right, thank you, Novia. And I love that you mentioned the importance of nutrition to childhood development, and also the existence or the need to ensure that our food environments, ensure that healthy food and good nutrition is accessible to children. So on that point, I'm going to pose a question to you, and I'm also going to invite Rosanna Pike, who is the advocacy coordinator at Heart Foundation of Jamaica, to chime in a bit. But my question for you, Novia, is I know you mentioned, or rather, 1 in 4 females and males, 22% females rather, experience food insecurity. As I know you mentioned food insecurity earlier in your presentation. Well, how can the recently announced school nutrition policy, how can it address this, and how can the data that exists be used to address malnutrition and childhood NCDs that are so prevalent within our country?
Well, the malnutrition and childhood NCDs, well, that is a many-layered area. But if we can talk about the critical importance of having this school nutrition policy in place, that will govern how we treat the nutrition of our children while they're at school. It is absolutely, it's really a game changer. And it will take a lot of us to support the government in implementing and also monitoring how the various schools are implementing this policy. What we're looking at is the opportunity to make sure that students, when they're at school and they spend a tremendous amount of time there, have access to food that is nutritious, that will support healthy growth, development, and general health and well-being. When we look at what is on offer, and I know Dashawn, the team at JAN, has been out there in the trenches along with our Heart Foundation colleagues and UNICEF as well, to make sure that students are aware of the impact of poor nutrition on their health. I'm aware of the feedback. A lot of students are upset. A lot of students are upset because they're like, the options that are available to them are all unhealthy foods. And it is really important that we make sure that, that young people are being enabled to, one, learn about what a balanced meal looks like. That young people are able to learn about the impact of some of these food, the intake of some of these foods on their health now and their health moving forward. As we know, NCDs is the #1 cause of death in Jamaica. So, eating a certain kind of unhealthy food every day may seem like, oh, I'm fine. But we also know that adolescents have a very high rate of overweight and obesity, high and growing rate of overweight and obesity that will impact them now and further on in their lives. So it is absolutely necessary for us to pull together. This is not just the government's policy. This is all our policy to make sure that it is implemented in accordance with you know, in the spirit of what it is, but also to make sure that we have our eyes on this, because it's one of those things that if your eyes are not on it, you know, we may lose some of the gains that we could have gotten from it. And I'll hand over now, but I really just want to first of all applaud Jayan for the tremendous work that you have done in advocating for this policy, to push it, to make sure that right now we're looking at, we're on the verge of approval, hopefully. And that has been, a lot of that is because you guys have not eased up the pressure. And I just want to congratulate Jayan and your affiliate organizations. It's a big success.
All right, thank you, Novia. And of course, I'd like to further that call to congratulate Jayan on all the work that we've put in towards calling for the SNP, and not just for the SNP, but for other regulatory frameworks that ensure that, or that seek to ensure that young people have access to healthy food within their environments, that they're cognizant of, as you said, the impact that these unhealthy foods have on them and on their future, what it means for their education, their livelihood, and what it means for our country in general. So, Rosanna, I believe you can chime in now.
Hi, good afternoon, everyone. I mean, my question was really zooming in on, you know, what Novia touched on it a bit earlier, but I guess if she can further do a little more deep dive, just for, you know, a wider understanding for our audience here on what any data that UNICEF, because I know you guys are big on research and you are for the children, for the youth. You know, what is your data saying about, you know, nutrition related disorders in Jamaican youth, you know, especially as in terms of overweight, malnutrition in terms of overweight, obesity? Because I mean, some people still have put malnutrition in a box. They don't know that overweight and obesity is a form of malnutrition because you have overnutrition and undernutrition. So, you know, just to kind of deep dive on any data that UNICEF might have on that as it relates to Jamaican youth.
Thanks for that, Rosanna. So, the data that we have is the data that's been out there for a while. It comes from the Global School Nutrition Survey, and I think the last one was done too many years ago now. I can't recall the exact year. But what it shows us is that obesity and overweight we're on the verge of an epidemic here, to be quite frank. I think, if I recall well, it showed that the rate of obesity in boys had doubled when compared to the previous survey, and that it was the rate of overweight, okay, obesity different from overweight. Obesity in boys had doubled, but it was growing among boys and girls. And overweight is moving along the same line. So what we know is that our young people, what they're eating is unhealthy. There's nothing else to say. What our young people, our children, and our adolescents are consuming is not healthy, and their lifestyles are also contributing to this lack of good health. We are not moving enough, and the food that we're eating is not nutritious food. That there is no other way to say it. That is what that statistic is telling us. Now, is that for many years, young people and people in general have been led to believe that this is a personal decision. What you eat is your decision, and what you eat is up to you, and you have choices. But there are some things that are fighting against you making a good decision on your health. There is marketing, where especially for children, some foods are marketed in a way that make that food just absolutely attractive, and a child is going to be drawn, and they know, our marketers are very good, and they know how to ensure that children are drawn to certain foods. When you go into the supermarket and you're at the checkout counter, it is not oranges and bananas that are sitting at the checkout counter where you're standing in a line and waiting. It's sweetie and all kinds of manner of sugar-laden goods. And you are standing there, and it's at the eye level of children. And there's a reason for that. When you are watching television, the kind of characters that bring or that sell certain foods are definitely geared towards children. It's not a hidden agenda. It is very out there, and it is unregulated, and the decision is not yours if you are so highly influenced. In addition to that, we know sugar is, I think I've read somewhere, don't quote me on this, but I've seen and read somewhere that sugar is a highly addictive substance, almost like some narcotic drugs. If you are eating a lot of sugar, you are simply going to crave it more and more and more. And so it is very important that we're looking at sugar content of foods that children are consuming. And what we find is that the more you eat it, the more it's wanted. And then parents have a challenge, because then the children may reject if they are really exposed to a lot of these sugar-laden goods. They may reject what doesn't feel like that doesn't give them that same reaction chemically in their body. So it's difficult. And so, I've seen so many parents say, boy, I have to give them this because it's the only thing they'll eat. It's also the thing that they have gotten very used to. And it becomes a little bit more difficult to have the children eat more healthy foods. So there has to be a lot of education for our parents who struggle a lot with children, especially if you have a picky eater. And then you also have the education that children need to get so that they can develop the ability to understand what is healthier and so on. But the food environment is such a big part of that decision. If I am hungry and all that is there is some oil-saturated meal, I'm gonna eat it because I'm hungry. So if there is nothing else on offer, or nothing else that is offered in a way that is just as attractive, the decision is already made for me. So it is really, really critical that our food industry is regulated so that they don't just think about the dollar more than they think about the health of children and adolescents.
All right, thank you, Novia. And I love that you ended off with that message. Calling our the food industry, as key stakeholders to not prioritize profits over persons' livelihoods, over their health, and to ensure that they're playing their part to secure the future of our children and of our country and of our world. And so I want to thank you for your contribution. I think that was a lovely response. And I think that would have perfectly answered Rosanna's question. But now I'm going to turn over to Mr. Patrick from JASL. And I just want to see if there are any indicators as to how many students are getting comprehensive sexuality education within schools. I know you mentioned that that's a gap that we're currently facing and that would have contributed to the high prevalences of HIV contraction within younger individuals, specifically in Jamaica. So over to you, Mr. Patrick.
I'm going to say comprehensive sexuality education as properly defined. If I should speak in that context, there is none happening in schools in Jamaica. Really. So there would not be enough. What is provided through the health and family life education curriculum is partial. It is not comprehensive sexuality. So there has to be, I think one of the things that we would have to look at if we are really supposed to get there is from the adolescent sexual and reproductive health policy. The adolescent sexual and reproductive health policy has been on and off trying to get that fully up and running. And as we just looked at the nutrition policy, I think we have to understand that when it comes to behavior change, while a policy in and of itself does not change behavior, when we want behavior change on such a large scale, a policy is very critical. And a policy is very critical because it does a few things. First of all, it creates a structure within which we operate. It creates that framework for long-term sustainability, which is what you want for behavior change. You don't just want to do it this year or this week and not do it again. The existence of a policy helped to shape social norms. People don't think that it's the norm to be talking about the subject matter of comprehensive sexuality in schools. This is not the place for it. So having a policy, it also contributes to shaping our social norms. Well, this is a position that is taken by our government because they think it is something important to happen. And then you will find that over time, more people come on board. A policy also creates that framework for accountability. As I said in my presentation, if HFLE is taught or not taught, then no big deal. There's no exam. There's nothing to answer to for. So having that policy framework helps to create that level of accountability. It also allows for resource allocation. If you have a policy that says comprehensive sexual education is critical in school, then you also have to allocate the resources so that that can be done. It will be the resources for having the persons who are trained, equipped, and comfortable delivering such. So the short answer to your question is that there is none at this time. The health and family life education curriculum comes as close as possible to, but we do not currently have comprehensive sexuality education being delivered in schools.
Thank you, Patrick. And again, it's quite alarming, these statistics or the lack thereof, and the fact that there's no comprehensive sexuality education within schools. It just begs the question as to whether there's any causative effects between this gap in knowledge and the high prevalence that we're seeing. So I thank you for making that connection, and I thank you also for reiterating the need for policy implementation and just bringing home the message that only until we have these policies can we see effective behavior change. So thank you once again. And I'm just going to invite Ms. Shelley Weeks, who is the Executive Director of Her Flow Foundation, to pose her question.
Thank you so much. And I just want to take a moment to echo Patrick's sentiment in terms of the sexuality health education as a part of our reproductive health education campaign at Her Flow. We visit over 100 schools a year. And it is a challenge for me with the guidance that I'm given in terms of whether or not I can say the word vagina in the classroom while we're talking about periods. So I really think that the policy has to be in place and the adults in the room need to find a common ground as to what it is that is going to be placed on the curriculum, because there seems to be some differences dependent on the institution, and it also depends a lot on how religious the institution is, because that reflects how much information they'll feel comfortable with you sharing with the students. One of the things that I want to ask about is usually in these conversations, period is not included at all. And period is everywhere, including in a lot of the adolescents who are going to school. And I hear the conversation around nutrition. And the truth is, a lot of the children are experiencing very difficult periods. Yesterday, I was at Denby High and I met a young lady who was diagnosed with endometriosis. She was 15. And so we are finding that not only are they having more difficult periods, they're having periods earlier. We have children in primary schools who have started their period at 8. So I just want to know, I don't hear it in the plans, but I think it should be included in there somewhere, about how we are going to address the reproductive health education that's showing up in our children younger and younger. And even though the girls, they display pain, a lot of the boys, I'm sure if they are tested, they will show that they might have some challenges where their reproductive health is concerned as well, that is going to cost them in the long run. And as long as we continue to talk about our low birth rate, this is something that we absolutely need to take a look at, especially from a policy level. What I would like to know, and I love the fact that UNICEF is here, I've been trying to find the funding myself to see if we can get a better look at what period poverty looks like in Jamaica island-wide. I can tell you from the schools that we visit what it looks like in the schools, but we have not been to every single school. Is there any plan, budget, any thought at all to getting this data done? And if so, we would love to be a part of it. But that's the question. Is there any plan to address period poverty in any way? And I think the best way to do it is to find out what the data actually says on a nationwide scale.
All right, thank you, Shillian. I believe is Novia still on? If
I
not, oh, you
Mhm.
are? Will you be
Yeah.
able to answer, respond?
Yeah, no, really, thank you for that contribution, Shellyan. It is an issue, and we are our partners are coming across this issue more and more. So right now, we don't have any program in place that goes beyond what we already support in terms of sexual and reproductive health. We do give support to the Health and Family Life Education Program. We support the Ministry of Health in its 44 adolescent clinics across the island, as well as other programs such as a Teen Hub program that the ministry also implements. And those issues are addressed in those spaces. Patrick has already spoken to some of the issues with HFLE, and you've also had some of the same experiences yourself. So there is much, much more work to do around period poverty. We would love to hear more about, as it is honestly something that, and I think I also have to congratulate your organization, Shellyan, for shining the light on period poverty in Jamaica. But that is also an area where there, as you've said, there's not a lot of information, and I'm not aware of any plan to look at this from any of our ministry colleagues. And we generally do support, or we're approached by the ministries to partner with them to find out what is happening in these areas. As to can we boost? We can look at how we're supporting this kind of information now. There absolutely needs to be much more done at school level and in communities and with parents around this so that we can better support our girls. And girl empowerment and support for our girls is definitely an area that UNICEF has prioritized. So perhaps we can talk to you to see how what exactly you're doing, what you have been, where are some of the gaps, and to see if there are areas where we can collaborate.
All right, thank you, Novia. And I'm going to take one last question. I'm seeing that Sitota has her hand up. After Sitota's question, we're going to go ahead and wrap up the session. Over to you, Sitota.
Okay, good afternoon, everyone. It was just a comment slash question on what was being talked about earlier with regarding to nutrition and movement. And I was just thinking about specifically the context of young girls, teenage girls, how they view movement and exercise. I think it's a part of the process of causing bad mental health because instead of viewing exercise and movement as a way to improve mental health symptoms, sometimes they view it becomes like kind of a part of body dysmorphia or viewing it as a way to treat their physical insecurities instead of like a solution to mental health problems. So I think that needs to be talked about more so we can shift the focus to it helping rather than contributing to the mental health problems.
All right, thank you, Sitota. I feel like that's quite powerful. Shifting our focus to mental health. So now that we're at the end of the session, I want to I want to reiterate what the message was that we see came up throughout the entire presentation, throughout the panel discussion, really trying to convince us that the data is speaking, the data is there, but the question is whether we're actually listening and utilizing this data to its fullest potential. So with our first presenter, Novia, we'd have seen her talk about, violence against children and adolescents, the epidemic rather, or the endemic rather, that is unhealthy eating, the role that the food industry has to play in ensuring that our food environments are, peddling and not reflecting the level of nutrition and healthiness that our children ought to experience. And she also would have spoke about the severe health consequences that violence against children would have, the negative ramifications on their development, the life and the lifelong manifestations that it would have. And then we'd see a shift over to Patrick now, who also spoke about the lack of knowledge and how that affected issues such as HIV prevalence within Jamaica, especially within our young children. He spoke about, the barriers to sexual and reproductive health care that persist within Jamaica and how this would leave many adolescents without the support that they need to live healthy and informed lives. And we'd have then went on to Professor Wendell Abel, who delved into mental health, specifically childhood trauma. He'd have looked at the ACEs and how different factors can affect young children throughout their lives and how these factors can manifest within their behaviors, within how they interact with each others, and how we as a society should transcend from our traditional view or question of asking what is wrong with the child, but now asking what has happened to that child. And so we want to thank all three of our presenters for what I'm sure everyone can agree was quite informative, was quite insightful, and leave us feeling empowered because, as I said, knowledge is power, and we can then go and use this data. This is my charge to you all, to use this data, to act on it, to bring about meaningful change, whether you're from the government, whether you're from civil society, whether you're from a youth network, any space that you take up, you can use this data to bring about change and use what you've heard today to call for better policies, to craft stronger advocacy campaigns, to design more responsive services, and to be more targeted in your interventions. I'd also like to thank the JN team, of course, myself, that Natalia. I want to thank Kayla Wright, our programs coordinator. I want to thank Chanil, or Project and Advocacy Coordinator. I want to thank Shanique, our Executive Director. A big thanks to Jonathan Atkins, our Communications Coordinator, who helped to put all of this together. Without him, this wouldn't have been possible. I want to thank Calvin, our Digital Media Manager, Officer rather, and everyone else who helped to ensure that this event was successful. I want to thank our partners, those from UNICEF, those from HFJ, those from HerFlow, those from SHEO, from NCU, from all the other organizations that would have represented today. And of course, I want to thank our audience for posing questions, for listening, for being here, for providing an open air. And I want to thank you in advance for taking all the data and the information that you'd have learned and putting in the action, putting in the work to ensure that it's fruitful and it would mean something in the long run. And I also want to call you all to join us for our next session in this town hall series, where we'll explore violence and children and what is the data saying about that. And we'll take a deeper dive into childhood abuse. We've looked at this already, peer violence, structural violence, and most importantly, how we respond to these instances of violence and abuse. So until then, I'm going to ask you all to stay safe, stay engaged, and let's continue the meaningful work and the energy that we've put in today. So thank you, everyone, and I'm inviting you all to come out again next week, Thursday, this time. Bye.
Thank you, Dashawn. Bye.